Good morning, good day to everyone. Starting our lecture today about hypocalcemia and calcium metabolism. My name is Sajad Hamidi. I am an internal medicine resident, and let's get this show running. So, as usual, we will start our lecture with the latest case we had regarding that uh, certain subjects. So, a 63-year-old female with diabetes, hypertension, and ischemic heart disease presents to our ER at some hour in the night. Also, she has ischemic heart disease and heart failure. She presents with a dyspnea for 3 days. On examination of that patient, she is conscious oriented, sitting on the bed, so she's not lying down, and there is audible inspiratory stridor, uh, which is biphasic, and there is also a bilateral lower zone fine crepitus extending to the mid zones. The patient is dyspneic and tachypneic. Her blood pressure is 160 over 80, and her saturation by oximeter is 82% on room air. So, an appropriate dose of diuretics and O2 were administered several hours after the patient is now non dyspneic. Her SpO2 is 96% on room air, but the stridor, as usual, is non affected by diuretics and it stays. So, the patient is still talking with a hoarseness in the voice. The patient relatives mentioned that the patient has been speaking like this, meaning with a hoarseness, since 2 years after the patient had her thyroid removed. The EKG showed for this patient a prolonged QT interval, and the machine read a corrected QTC of 600 millimeters, which is markedly increased, and a serum calcium levels of 5 milligram per deciliter. And our question is, what is the next step to be done for this patient? Of course, you have a prolonged QT, and we know that a prolonged QT is a predisposition for torsades de pontis, which can uh, very well rapidly change into a ventricular fibrillation. Now, we do not lack the courage nor the inclination to give our patient DC shocks in the ER, but let's spare them the this horrible fate. And so, what do you think, guys? We should do for this patient? Should we uh, give her an anti-arrhythmic agent such as lidocaine? Should we give her calcium? Should we give her potassium? And I mean, it's a pretty simple question, but it's for to get your mind running through this case as we go about our lecture. We will answer it, of course, by the end of this lecture. So, first, let's talk about calcium and why the change in calcium function is so detrimental to us human beings. The calcium ion plays a critical role in normal cellular function and signaling, regulating diverse physiological processes such as neuromuscular signaling, cardiac contractility, hormone secretion, and blood coagulation. Now, of course, we know that pesky diagram of the coagulation cascades, and then the activation of the platelet is dependent on calcium ions. So we have a little bit of examples regarding the calcium effect on the contractility of cardiomyocyte, the effect of calcium on the contractility of the and relaxation of the smooth and skeletal muscles where it is stored in the sarcoplasmic reticulum. And finally, we have another example of the effect of calcium on the neuromuscular uh, neuromuscular propagation of action potentials and the neuronal signaling processes. So we see that the calcium enters through calcium voltage gated channels, which allows these vesicles containing either glutamate, nicotine, or muscarine, or whatever neuromuscular receptor it have to be secreted into this neuromuscular or a neuro junction. Now, a lack of calcium will cause instability. So let's be a little bit more focused on this part. So it causes instability of this junction. So it means that it will not cause hypocalcemia will not cause an inhibition but an instability. So it means that these neurons, these receptors might secrete at haphazard rates, so an uncontrolled rate, while a hypercalcemia would cause an inhibition. And that's why when you have a patient with hypocalcemia, you would expect him to go into arrhythmia, and you would expect him to go into seizure and hyperreflexia. While on the other spectrum, a patient with hypercalcemia would expect him to have a dull reflexes, to have a monotonicity, to have a depression like symptoms or a full blown depression, renal stones, and a decrease in all over action potential dependent activities, which is basically everything. So, as we talked about the importance of calcium ions, let's talk about how much it is important by how much the body spends on regulating it. So, the extracellular calcium concentration is maintained within an exquisitely narrow range through a series of feedback mechanisms that involve the parathyroid hormone PTH and the active vitamin D metabolite 125 dihydroxyvitamin D, which is called also calcitrol. These feedback mechanisms are orchestrated by integrating signals between the parathyroid gland A, kidney B, intestine C, and finally bone D. So let's see what happens here by this diagram. So we have a decrease in extracellular calcium, which causes the receptors found in these four small parathyroid gland to be activated via their calcium sensing receptor proteins. And the parathyroid gland will respond by increasing their parathyroid hormone release, which causes one, an activation of the osteoclastic cells via, of course, the osteoblastic cells, but I will leave this details for orthopedicians to explain it. So it activates the osteoblast, which activates the osteoclast to resorb bone, and of course bone has calcium, and this calcium would be excreted in the bloodstream to maintain extracellular calcium levels. It also affects on the kidney to do its job of metabolizing the vitamin D from its inactive form to the 125 dihydroxyvitamin D, which will also affect on the kidney to increase its resorption of calcium, and on the intestine to increase absorption. So this is reabsorption, which we call resorption, and absorption of the calcium from the intestine, which will ultimately lead to an increase in the calcium back to its normal level. Now, of course, if it is the other way around, when we have way too much calcium, then these cells would be inhibited and there is no parathyroid gland and less vitamin D, so no resorption, no resorption from the bone, no reabsorption from the kidney, and no absorption from the intestine. Etiologies of the hypocalcemia. Although there are many potential causes of hypocalcemia, impaired PTH production and impaired vitamin D production are the most common etiologies. Impaired PTH secretion may be secondary to magnesium deficiency or to activating mutation in the CASR gene or in the G protein mediating the CASR signaling. So the CASR is the calcium sensing receptor gene and the protein found in the PTH cells, and it is autosomal dominant condition. And basically what it does is that the parathyroid gland does not get activated when there is less calcium than it should, and so there is no normal function of the PTH hormone and parathyroid gland. So, which suppresses the PTH, leading to effects that are opposite to that occur in FHH. FHH is the familial hypercalciuria syndrome, And basically, what happens in that condition is that the CASR gene is overactivated, so it works when it shouldn't, and it allows the parathyroid gland to secrete even more hormone, which leads to more calcium in the bloodstream, weaker bones, and of course, renal stones. Hypocalcemia may also occur in conditions associated with severe tissue injury, such as burns, rhabdomyolysis, tumor lysis, and pancreatitis. Now, basically, what it means is that we have a total calcium level and an ion calcium level, and the active part is the ion calcium level, which is about 10 to 20% of the total calcium. And these conditions, all of them, including cancers, would lead to a less protein in the body. So, a less protein means less ability to bind calcium and more free calcium ions. Now, this might be a reason to see hypocalcemia by lab, but without any of its features present. That's because the calcium ion is in normal level, but the total calcium is in low supply. Uh, the cause of hypocalcemia in this setting might include the combination of low albumin and hyperphosphatemia, which is a binder of calcium, just like albumin. Tissue deposition of calcium, which occurs most commonly with the pancreatitis because of the if we do an imaging after an episode of severe acute pancreatitis, we would see a bone-like opacities on the CT scan. This is because the calcium is being deposited in the autodigested tissue. And if we do a calcium level after a case of pancreatitis, we would see hypocalcemia. That's because the calcium is being deposited in these tissues. And of course, it might also be due to an impaired PTH secretion because this condition will be depleting on the human body, and the hormone production process would require energy, proteins, and metabolites. And of course, the reason that we did not mention here, maybe we mentioned it a little bit here, is the impaired vitamin D production or impaired vitamin D stores. And this occurs, this might be either due to malnutrition or less exposure to sunlight. And the other important cause is malabsorption of the vitamin D or calcium because of Crohn's disease, ulcerative colitis, and other maybe short bowel syndrome, and what other reasons that might affect absorption. Clinical manifestation of hypocalcemia. Asymptomatic presentation is the most common, and it is especially in the cases where the decrease in serum calcium is either rare or chronic. Moderate to severe presentation is associated with paresthesia, usually of the fingers, toes, and circumoral regions. And a really good example to see these changes, the hypocalcemic changes, is with the patient with a panic attack because they hyperventilate, and this hyperventilation causes blood alkalosis, and the alkalosis shifts the metabolite towards hyperkalemia and hypocalcemia because it allows the calcium to bind more with the blood proteins, including albumin. And so patients with hyperventilation would present with a kyphostic sign, which is, although it is also normal in 10% of normal individuals, but basically it's by tapping the region near the temporomandibular joint, and an ipsilateral contraction of the masseter muscles would occur, and a carpal spasm, which we can induce by inflation of a blood pressure cuff to 20 millimeter mercury above the patient's systolic blood pressure for 3 minutes, which is called the Trozier sign. But as we have seen with patients with panic attack, it may occur spontaneously. And severe hypocalcemia induce seizures, carpopedal spasm, spontaneous without the Trozier sign, also bronchospasm, evident by either rhonchi or severe stridor, laryngospasm, and a prolongation of the QT interval. These are the kyphostic sign and the Trozier sign, and we see a gentle tapping near the temporomandibular joint would cause this winking and contraction of the mouth angle towards the tapped region, and this is caused, of course, by a low calcium, so it causes instability and irritability of the neuromuscular junction, and the Troze sign, which resembles an Italian chef presenting you with a well done thin crusted pizza. Diagnostic approach. In addition to measuring serum calcium, it is useful to determine albumin, phosphorus, and magnesium levels. As we have mentioned earlier, phosphorus and albumin are both are a substances that tends to combine with calcium, and also it allows us to determine the total and free calcium ions. Magnesium is also very important because some cases of refractory hypokalemia and hypocalcemia is caused by a deficiency of the magnesium levels. Determining the PTH level is central to the evaluation of hypocalcemia. A suppressed or a low PTH level in the setting of hypocalcemia establishes absent or reduced PTH secretion, hypoparathyroidism, and by contrast, an elevated PTH level, secondary hypoparathyroidism, should direct attention to the vitamin D excess as the cause of the hypocalcemia. A nutritional vitamin D deficiency is best assessed by obtaining 25 hydroxyvitamin D levels, which reflects vitamin D stores. And this is important. So the 25 is for the stores, while in the setting of renal insufficiency or suspected vitamin D resistance, a serum 125 is informative. Why? Because if we have an renal insufficiency, then we would have a low 125 level. But if we have a good vitamin D stores and a good 125 and a high PTH, then this is a case of vitamin D resistance. Treatment. It depends on the severity of the hypocalcemia, the rapidity in which it develops, and the accompanying complications, seizures, laryngospasm, etc. So we will differentiate it into acute symptomatic and chronic hypocalcemia. So with the acute symptomatic hypocalcemia, we should give calcium gluconate 10 milliliters, 10%, which contains 20 milligrams or 2.2 moles intravenously diluted in 50 ml of 5% dextrose or 0.9% sodium chloride, given IV over 5 minutes. And this is the acute symptomatic. If after the acute symptomatic dose the patient is continuing to have hypocalcemia, then this requires a constant intravenous infusion of typically 10 ampoules or 900 milligrams of calcium in 1 liter of 5% dextrose or 0.9 sodium chloride over 24 hours. Accompanying hypomagnesemia, if present, should be treated with appropriate magnesium supplementation. Now, the chronic hypocalcemia and usually due to hypoparathyroidism is treated with calcium supplementation, 1000 to 1500 milligrams per day of elemental calcium in divided doses, and either vitamin D2 or D3, 25,000 to 100,000 international unit daily. If not for the vitamin D2 or 3, we can give calcitrol, which is the activated form of vitamin D 125 as 0.25 to 2 microgram per day. Also, PTH and NatPara is now approved by the FDA, and it's used for the treatment of refractory hypoparathyroidism, which represent an important advance in the treatment of these patient categories. Vitamin D deficiency. If vitamin D deficiency is diagnosed, then we have to assess whether it was due to nutritional vitamin D deficiency or malabsorption. So we treat it with vitamin D supplementation, of course, and the dose depending on severity and the underlying cause. For the nutritional vitamin D deficiency, generally responds to a low doses of vitamin D, so a 50,000 international unit 2 to 3 times per week for several months, while vitamin D deficiency due to malabsorption require much higher doses, 100,000 international units per day, or more. And the treatment goal, of course, is to bring serum calcium into the low normal range and to avoid hypercalciuria, which may lead to nephrolithiasis, which is renal stones. Some global consideration in countries with more limited access to health care or screening laboratory testing of serum calcium levels, primary hyperparathyroidism often presents in its severe form with skeletal complications, and in contrast to the asymptomatic form that is common in developed countries. Vitamin D deficiency is also very common in countries with extensive sunlight, like India or Iraq, due to avoidance of sun exposure and poor dietary vitamin D intake. And with that, we conclude our lecture about the hypocalcemia. And regarding the question at the beginning of the lecture, this lady was given the acute treatment for hypocalcemia, which is the 10% over 5 minutes, and then she was admitted into the cardiac care unit uh, for a maintenance of 24-hour calcium level. Furthermore, a PTH study and magnesium study showed both mild hypomagnesemia and hypoparathyroidism. It appears that the patient's total thyroidectomy resulted in a recurrent left recurrent laryngeal nerve injury and uh, an iatrogenic hypoparathyroidism, which caused her hypocalcemia. The patient did not exhibit any neurological sign of hypocalcemia, but her EKG maintained a prolonged QT. Albumin levels were within normal range. The patient is now on high dose calcium and magnesium replacement and will be discharged on oral calcium and magnesium supplements with vitamin D. Thank you and goodbye.